virtual presentation. Dr. Magy from Egypt will be presenting on Egyptian Gaucher disease type 3 patients, a unique cohort typical with atypical presentations.
Hello, everyone. Good afternoon. I would like to thank Oslam and the organizing committee for the kind invitation to share the data of our unique Egyptian GD3 cohort. I'm Magy Abdelwahab. I'm a pediatric hematologist in Cairo University Pediatric Hospital, one of the biggest tertiary hospitals in the Middle East. And we are one of 7 treating centers for Gaucher disease. We have around 130 patients in Cairo University, and they're mostly GD3 patients. If you look at this photo, this is one of 4 hospitals, and the patients get to receive their treatment partly at home-based therapy, and the rest, they would come every other Tuesday, divided into 2 groups. Where they get hospital-based therapy in our hematology outpatient clinic that resides on the 1st floor, and it works at the Gaucher Disease clinic every Tuesday. My presentation will be highlighting the uniqueness of our cohort, typical and atypical presentations. I have no disclosures. Okay, so I'll give a very brief introduction of Gaucher disease, the wide heterogeneity of our Egyptian GD3 patients, though around 70 to 80% are homozygous for the mutation L4-4P, the commonly reported worldwide. I'll be going through the typical and atypical clinical presentations of our cohort, and at the end, I will be highlighting its uniqueness. So a bit of history here. I believe history is very important, as we really owe a lot of credit starting to all these people, starting from Philippe Gaucher and ending by Brady Roski, after nearly a century, and the ultimate discovery of the enzyme replacement therapy. Now, regarding the pathophysiology of Gaucher disease, in very brief terms, being a hematologist, the monocytes adhere to macrophages in the marrow or in bone marrow, as you can see here, or in other tissues and organs. Now, what happens here is due to mutations in the GB1 gene, which are unique for the Gaucher disease, they lead to markedly decreased activity of the beta-glucocerebrosidase enzyme, which converts the glucosyl ceramide into ceramides and glucose. So, the Gaucher cells, the macrophages, once they are resident, they accumulate the glucosyl ceramide by phagocytosis and become our unique end-stage Gaucher cells. Gaucher disease constitutes 48% of the single lipidosis in Egypt, coming second in prevalence after the MPS. Classically, as we all know, GD has 3 phenotypes depending on the absence or presence and severity of neurological signs. Then type 1, or the non-neuropathic, then the NGD, which includes types 2 and 3. However, it's very important to note here that the demarcation between the neuropathic variants is imprecise, and it's more accurate to consider such phenotypes as a continuum of disease, as we are going to present in the World 2024 together with Oslam and Amy. The neuropathic forms comprise about 6% of GD, with type 3 comprising about 5%. Very interestingly, type 3 Gaucher disease has a very high prevalence in the Eastern populations, ranging from 30% in Japan up to 60 to 70% and even more in some areas in Egypt, showing a very high prevalence in Egypt. Now, this slide, though busy, I would like to think of it as a quite interesting slide. It shows the very wide phenotypic spectrum of our Egyptian cohort. One side here, regarding the visceral manifestations, you will find very mild hepatosplenomegaly and mild growth delay. On the other end, you will find huge hepatosplenomegaly together with anemia, recurrent blood transfusion. Unfortunately, you can't see that on the slide, but that patient had severe thrombocytopenia, the platelet count less than 10,000, which we rarely encounter in children with Gaucher disease type 3. Also, regarding the atypical presentation, you would find that that 5.5-year-old who presented in infancy and was started very early on enzyme replacement therapy developed lymphadenopathy due to infiltration with Gaucher cells and calcifications, though on 60 IU per kg biweekly. Now, regarding the neurological manifestations, you will find at one end of the spectrum here, these two siblings with the homozygous L4-4P, yet they haven't even yet shown the gaze initiation failure or the supranuclear gaze palsy, the hallmark for diagnosis of NGD, as well as this little girl who has now grown to be a teenager. She only has very mild gaze initiation failure. On the other end of the spectrum, you will find that young man who has severe squint, kyphoscoliosis, seizures that are not responding to anti-epileptic drugs, and severe cognitive and behavioral changes. Now, in the middle here, you will find these two very interesting children who are presenting with mild motor delay, and they have mainly the kyphoscoliosis and the behavioral changes, but they have very severe visceral disease, lymphadenopathy, and lung involvement. Now, patients in general can present with type 3 Gaucher disease as early as during the first 6 months of life and as late as adulthood. However, the majority of patients present in childhood. The typical clinical scenario is an infant presenting with hepatosplenomegaly, anemia with or without thrombocytopenia, and a mild motor delay, plus or minus mild bulbar symptoms, usually dysphagia. Regarding the bulbar symptoms, they would include stridor, dysphagia, and speech problems, ranging from delay in speech to dysarthria and inability to talk. Though bulbar symptoms are reported worldwide in GD3 patients, yet they have a high prevalence of 37% in our cohort. Regarding the eye signs, about 97% of our cohort have supranuclear gaze palsy, and it is usually to horizontal gaze, but a significant number of patients have it to both vertical and horizontal gazes, or have both horizontal and vertical saccades, and usually with the compensatory head thrusting. Some patients would show nystagmus, and very interestingly, we have a very high prevalence of convergent squint of 22% in our GD3 cohort. The cognitive profile is quite variable, which was assessed by both the Whistler scale as well as the social Vineland scale, ranging from 85 at one plus or minus 38 at one end of the spectrum to 68 plus or minus 15 at the other ends of the spectrum. Now, regarding the atypical neurological involvement of our GD3 Egyptian cohort, I would like really to highlight that the stages show not only a high prevalence, but also a variability in type, focal with generalized, with secondary generalization, generalized, complex partial, and very few patients have myoclonic epilepsy. We reported that very interesting phenomena of sudden unexplained death of epilepsy at a mean age of 6.7 plus or minus 5 years in about 20% of our cohort who passed away. Behavioral problems are very variable and have a very wide phenotypic spectrum and have two peaks at two different ages. And they would include irritability, antisocial behavior, anger, and very aggressive behavior. It would really be great if you can read these two papers, because you can find them and hopefully interesting. Now, regarding the typical non-neurological manifestations, as we pointed in that busy slide, they would include the hepatosplenomegaly, anemia, and thrombocytopenia, as well as the growth delay. Regarding the pulmonary involvement, it can include recurrent chest infections, wheezy chest, which can be an initial presentation, very interestingly. So we really have to think about Gaucher disease in few patients who are presenting with recurrent wheezy chest. Radiological findings, they would include the interstitial lung disease in 70% of patients, whether symptomatic or asymptomatic, consolidation, bronchiectatic changes, as well as many other changes. Bone complications include the bony aches in many patients of different variability, avascular necrosis of the femur, fractures, especially in those with Z scores more than 2.5 standard deviation, and osteopenia. And interestingly, in few patients, or actually not few, in some patients who have osteopenia, not reversible or not responding to ERT, they responded to the bisphosphonates. Eye complications included the infiltrates of the cornea, the vitreous, and the retina, unfortunately, with visual impairments in few of our patients. Kyphoscoliosis and the cardiac calcifications in the well-known homozygous D409H mutation. The atypical non-neurological GD3 manifestations included the high prevalence of lymphadenopathy or infiltration of the lymph nodes with Gaucher cells, typically the mesenteric, and in some patients also the mediastinal, and in very few patients it would be generalized, as well as the Gaucheromas. And this is actually the biopsy from one of our patients, and it can be up to 25% in our cohort. The dental complications included very interestingly infiltration of the dental bulbs with Gaucher cells. Now, regarding the heart, we need to pause here, as we reported pulmonary hypertension in our pediatric cohort, as well as calcifications in our homozygous L4-4B patients, and that's quite unique. One of our patients had hepatopulmonary syndrome and unfortunately died while giving birth to her baby. And 10% of our children have liver cirrhosis. Again, the second important pose here. Radiological findings. Some of the typical radiological findings would include a CT chest here of this patient, the one that you saw with kyphoscoliosis, if you remember him in the busy slides, with a diffuse pulmonary interstitial disease, air trapping, and early parahilar bronchiectatic changes. Interestingly, his urological findings were stationary, and his symptoms regressed. Pulmonary symptoms. This is an echo, again, of a D409, of a homozygous D409 patient at the age of 16 years, showing here mitral regurg, as well as significant mitral leaflet calcifications. This patient is one of 7 patients with the homozygous D409 patients. She unfortunately passed away 1 day post-operatively, yet we have 2 who have performed surgery and are now on anticoagulants, one for a couple of years and the other for a year. Now, the atypical radiological manifestations include here this patient who is showing on his initial CT abdominal and mesenteric lymphadenopathy. Here, the largest 3.5 centimeters, and a heterogeneous pelvic-abdominal mass with cystic areas. Very interestingly, after 7 years on ERT, the patient showed significant regression of both the pelvic-abdominal mass and the lymphadenopathy, though, of course, the calcifications were still the same. Now, our unique Egyptian cohort, I would say the uniqueness can be a reason for its nomenclature as an Egyptian phenotype. Now, what have we got here that says that our Egyptian cohort is unique? Though patients have the same genotype in 70 to 80%, there is intrafamilial heterogeneity. Scoliosis is present in all our GD3 patients. Scoliosis, not kyphoscoliosis, whether it's a clinical sign or a radiological findings, with using the COPS angle on X-ray. Lymphadenopathy and granuliomas are prevalent in around 25% of patients. There is regression of clinical symptoms and or radiological findings of the lung, as well as the lymph nodes, as we saw in the previous slide, after receiving ERT for a long duration, usually a mean of 7 years. Now, the unique reporting of cardiac calcification, especially aortic calcifications, though mild, not severe, as is reported in the homozygous D409H, but significant and reported in a significant number of our patients with the homozygous L44P. And the infiltration of the dental bulbs of Gaucher cells, which was never reported before, and the unique phenomena of sudden unexplained death of epilepsy, as well as the behavioral abnormalities noted in our cohort. Bulbar symptoms and behavioral abnormalities can show regression in patients receiving ERT that can be attributed to being extrapyramidal symptoms. Now, thank you. I would thank my patients and their families because I believe I owe them so much. And these are our adult patients who are doing really well. And this is our nurse who was really doing a very good job, but he passed away, God rest his soul. And this is our international group, and this is our national group. And I think you remember the picture of those two patients. So this is how they started off, and this is how they grew across the years. And I always want to see our patients shine like this drop of water on a leaf of lotus. Thank you.